Hello and welcome to our new topic. Today we will discuss pharmacological management of lower gastrointestinal disorders, specifically constipation and diarrhea. These are extremely common complaints in both outpatient and inpatient practice. Although they appear simple symptoms, they reflect complex disturbances in intestinal fluid balance and motility. Therefore, drug therapy must be guided by physiology rather than habit or overuse. So, let's start. By the end of this session, you should be able to classify laxatives and antidiarrheals based on mechanism, explain how each class works, recognize adverse effects, and choose drugs rationally in specific clinical situations. Always remember, treat the cause first, drugs second. The intestine handles enormous volumes of fluid daily. Around 7 liters are secreted and most is reabsorbed. Only a small fraction appears in stool. Therefore, even minor disturbances in secretion or absorption can lead to diarrhea or constipation. This highlights how sensitive the system is. This diagram shows the normal balance between ingestion, secretion, and absorption. If absorption exceeds secretion, constipation occurs. If secretion exceeds absorption, diarrhea occurs. So most drugs act by shifting this balance by a variety of mechanisms. Constipation is not just infrequent stool. It includes hard stool, straining, incomplete evacuation, and need for manual maneuvers. Clinically, it is a symptom, not a disease. Therefore, treatment should address the underlying cause. Most constipation is functional, caused by low water or fiber intake, dehydration, sedentary lifestyle, and ignoring defecation urges. Therefore, lifestyle modification should always precede drug therapy. Also, some drugs may slow down bowel movements and cause constipation. Systemic diseases like hypothyroidism, diabetes, Parkinson's disease, and drugs such as anticholinergics and opioids also reduce motility. In these cases, treating the disease or adjusting medication is more important than prescribing laxatives. The first step is always hydration and lifestyle correction. Laxatives should be last line because their overuse can worsen bowel function and create dependence. Bulk agents like psyllium absorb water and increase stool mass. They mimic natural fiber. They are safest and most physiological. Hence they are first line in chronic constipation. The lubricants or fecal softeners reduce stool hardness and ease passage. They are useful when straining must be avoided, such as post-surgery or hemorrhoids. Osmotic agents retain water in the lumen. They soften stools and increase volume. Lactulose is especially important, not only for constipation but also for hepatic encephalopathy. The stimulants irritate the mucosa and stimulate peristalsis. Another name for these drugs is purgatives. They are effective but may cause cramping and dependence. Therefore, they are best reserved for short-term use. Lactulose is a non-absorbable sugar. It draws water osmotically. Because it is not absorbed, it acts locally and is safe. It has a unique additional benefit in liver disease as discussed next. In cirrhosis, the functional parenchyma of liver is reduced, leading to reduced metabolic capacity. That is why ammonia, which is a metabolic byproduct, accumulates and causes encephalopathy. Lactulose acidifies the colon, converting ammonia to ammonium, which cannot be absorbed. Thus, it lowers systemic ammonia. This is a classic example of a drug with dual action. These diagrams visually explain how reduced motility and increased absorption produce hard stools. The relationship between intake, secretion, absorption and transit time is linked to explain the mechanism. Diarrhea is increased frequency or liquidity of stool. It reflects excess secretion or reduced absorption. The most dangerous consequence is dehydration. Causes may be infectious or non-infectious. Always identify the cause first. Symptomatic drugs without addressing infection can be harmful to the extent of being life-threatening. The cornerstone is rehydration. Drugs are secondary. This is a very important clinical message. Fluids save lives, not antidiarrheals. Oral rehydration solution uses glucose-mediated sodium transport to enhance absorption. This is a brilliant example of physiology-based therapy. It is the single most life-saving intervention in diarrhea. Only indicated when infection is confirmed or strongly suspected. Overuse leads to resistance. Rational prescribing is essential. Opioids with or without anticholinergics can reduce peristalsis functionally. Kaolin, pectin, and psyllium bind toxins and water. Their effect is mild but safe. Octreotide and clonidine reduce intestinal secretion. Useful in secretory diarrhea. These are more specialized therapies. Opioids like loperamide reduce motility and secretion. They are effective for non-infective diarrhea but dangerous in invasive infections because they may retain toxins. This can lead to septicemia and death, especially in children suffering from acute gastroenteritis. Surface-acting agents like psyllium, kaolin and pectin are commonly used as over-the-counter preparations and help control diarrhea. They primarily reduce the contact between the intestinal mucosa and diarrhea-causing substances or irritants. Cholestyramine is helpful when the primary reason for diarrhea is excessive bile salts. Anti-secretory drugs like octreotide or clonidine have shown efficacy in certain endocrine tumors and other such conditions. This slide visually demonstrates excess secretion and rapid motility, and how various drugs may help in such conditions. Serotonin receptors regulate motility. 5-HT3 blockers reduce diarrhea-predominant IBS, while 5-HT4 agonists enhance motility in constipation-dominant IBS. Alozitron is a 5-HT3 antagonist that has been approved for the treatment of diarrhea-dominant irritable bowel syndrome. Other 5-HT3 antagonists, such as ondansetron, granisetron, dolasetron, and palonosetron, have been approved for the prevention and treatment of nausea and vomiting. However, their efficacy in the treatment of IBS has not been determined. In contrast, for constipation-dominant IBS, tegaserode, which is a partial agonist of presynaptic 5-HT4 receptors, helps stimulate local CGRP-dependent peristalsis. This shows how receptor pharmacology guides rational drug therapy. In many instances, diarrhea benefits from a variety of alternative treatment. For example, probiotics restore gut flora so that the opportunistic diarrhea-causing organisms are kept under check. Zinc improves immunity. Diet modifications support recovery. Non-drug therapy remains important. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!